Right, we can see the PowerPoint.
Okay, hopefully I'm audible to all.
Yes.
Yeah.
Lovely.
Yeah. So I hope everybody had a very fine day today. I'll start off, Doctor.
Yes.
Yeah.
Sure.
So a very fine good evening to one and all. Thank you for such a sweet introduction. And basically, I am working here in PHOTONIX Imaging Solutions as an oral and maxillofacial radiologist. And basically, PHOTONIX Imaging Solutions is a coming together of many of the people of our own fraternity. That is maxillofacial radiologists, maxillofacial pathologist, general dentist, all have come together to give you a final destination to all your dental imaging needs. Now, when we talk about dental imaging, first, what comes to our mind is our bread and butter intraoral periapical radiographs, our panoramic radiographs, lateral sets, our AP views, PA views, and your hand and wrist radiographs, and so on and so forth. All these two-dimensional radiographs are our bread and butter, and they are very much essential in moving forward to a proper diagnosis and a proper treatment plan. Then again, what we are here today is to discuss about a certain model or novel modality, but I wouldn't call it new or even relatively new. I would call it an established dental imaging modality that is required in dentistry in our field today. That is the cone beam computer tomography. Now, cone beam computer tomography is a very vast subject, and it is difficult to bring it into a small session, but still, I would like to just outline and discuss about why CBCT is needed and how it will benefit you in your day-to-day clinical practice. Now, as you can see, I hope the images are not clear. I don't hope, but I feel that the images are not clear right now, and the wordings are also not clear. Only my name and the logo of the PHOTONIX Imaging Solutions is clear. This is deliberate. This is what we know. We now know of CBCT. Basically, we are all a bit ignorant in this field because we are just starting out with CBCT. So we are all a bit ignorant, but what we need to do is we need to learn every day. Learning never stops. And hopefully by the end of this session, I'd like to, just open a window to how to understand CBCT. I'll just give you a brief exposure on how to understand CBCT so that you can take it in and move forward with it. So initially, when we talk about understanding something, we need to ask certain questions. The why, the when, the how, the why not, and the when not to, and all this. In today's session, we will brief it. We will reduce it to two questions mainly. That is why CBCT and when CBCT. So by the end of the session, we'll have some inkling of what we are talking about right now. Basically, I was talking about dental imaging modalities earlier, and I was telling you that the bread and butter intraoral periapical radiographs and all those two-dimensional radiographs are very much essential for our day-to-day practice. But sometimes, just sometimes, it might not tell you the whole story. I'll explain with this particular figure here. You can see that on one side, there is a panoramic sectional radiograph that is there. And on the other side, as Dr. Binu sir was telling, it is always 3D is always fun. And so I was going with fun, and this is our Super Mario. He's going to save our princess. But the thing is, he's in two dimensions. The only thing he can do is he can run in the x-axis and he can jump in the y-axis. So when he runs in the x-axis, he's moving forward. And when he jumps in the y-axis, he's hitting those question marks and getting big rewards. So basically, similarly, this two-dimensional radiography has its pros, but it also has its cons. Just come back to the panoramic radiograph that is beside the Super Mario screen. You could see that there is some pathology there. You can see, if you clearly visualize, you can see that there is a radio opacity on the periapical region of the tooth 1-1. If you can be more, observant, you can see that there is also another radio opacity on the
Doctor, we can, hello?
Hello, yes.
Sorry to interrupt, but we can only see that PHOTONIX slide. We cannot see
the
image.
I'm really sorry. So is this not moving forward? I mean,
no. We are on Dr. Vivek G.
Okay, sorry. So I'll try. I'll stop the sharing and then I'll try once more.
Yeah. Try once again.
Right. Thank you. Is it visible right now?
Right, 2D versus 3D. Yes.
Yeah. So just a minute. Yeah, so I was talking about why and when of CBCT. I mean, I hope you, I mean, I feel you have not seen all these slides. So basically, I was talking about 2D versus 3D and how it might sometimes the 2 dimensions might not give you the whole story. And I was talking about Super Mario, the prince was going to save the princess and all those things. And you can see an panoramic sectional OPG wherein there is a radio opacity on the periapex of the tooth 1-1. And if you're observant, you can also see another radio opacity on the apex of tooth 2-1. I hope this is clear to you all now, Doctor. These slides are clear, right?
No, we are still on 2D versus 3D.
Okay, basically, I mean, you can see the Mario and the OPG images.
Yeah, we can see that.
Okay, okay. I'll just shift it. Can you see another Mario now?
Yes.
Yeah. So this Mario is more. He's beefed up. He's happy. He's more healthy. This is because he has got an X-axis, he has got a Y-axis, and he has got a Z-axis. He has got a third dimension. That is why he is more lifelike. Similarly, when you look at the images beside him, you can see that these are the same images of the same teeth and radio opacity in question. Here, you will be able to better visualize the presence of a mesiodens that was present. I mean, I'll go back to the other slide. You can see a radio opacity on the apex of tooth 1-1, and the same image, you can see that there is a mesiodens on the apex of tooth 1-1, which is buccally placed, which is inverted such that the coronal portion of the mesiodens is towards the nasal cavity. It is dilacerated. There is a bend at the cervical third of the root, and it is away from the tooth 1-1. So you get all the information that is obtained that you can get from a 2-dimensional image, but also you get so much more. You get that it is buccally placed, it is inverted, it is dilacerated. All this was not, clearly visible in the 2-dimensional image. So that is what I was telling, that sometimes 2 dimensions might not tell you the whole story. So with that, I'll just up the ante, and then again I'll use Mario here. Again, here the 2-dimensional Mario is flat. He's lifeless, whereas the fist up in the air, happy Super Mario is a 3-dimensional figure. Similarly, you can see that the impacted canine, you cannot see whether it is buccally placed, it is palatally placed, or there is resorption of the roots of the adjacent teeth. But when you use a 3-dimensional imaging modality like a CBCT, you can see axial section, coronal section, as well as a sagittal section. So all these 3 sections, I'll talk about these terminologies, axial, coronal, and sagittal. But what we can get from these images is that you can basically get a more accurate labio-palatal localization. You will be able to get a better concept of the surgical access, how to access this canine. And you will also get more information beforehand itself about the potential complications that might arise from such a surgery if you go blindly. So you can save more canines, you can save more teeth, you can save more time, you can save more of your practice by using these 3-dimensional modalities like CBCT. So with that, I'll talk about terminologies. I was talking about axial, coronal, and sagittal. Most of us might know what it is, but still, just to refresh, basically the coronal and sagittal and axial planes are orthogonal planes. That is, they are at 90 degrees to each other. And what happens is the axial plane is a horizontal plane, whereas the coronal and sagittal planes are vertical planes. So just think about coronal plane. In the image, you can see that the coronal plane is dividing the skull into a front and a back. That is an anterior portion and a superior portion. Posterior portion. So the coronal divides it into a front and a back, whereas sagittal would be such that it will divide your skull into 2 lateral halves, a right half and a left half. And the axial plane would be such that you will get a horizontal cut, wherein you will be divided into a top or a upper portion and a lower portion, bottom portion or a lower portion. So this is the basic terminology that we might use in 3-dimensional modalities, axial, sagittal, and coronal. I'll just illustrate with a video here. You can see that it is coming from top to bottom, that is up to down. So this is an axial half. Now this is from right to left. So this is a sagittal section. These are sagittal cuts that you can see. And then the third one, it is coming from front to back. So it is a coronal section. I'll just say once more, this is an axial cut wherein you can see it is coming from up to down. And then the right to left sections would be the sagittal sections, wherein you are going from right to left. The cuts are from right to left. And when you go from front to back, it is coronal sections. So I'll use these axial, coronal, and sagittal in a case here, and we'll discuss about how 2-dimension is again better. I mean, 3-dimension is always and giving more impetus to the 2D image, whatever we got. You can see here that there is a sectional panoramic radiograph. And in this case, you can see that the patient has a supplemental tooth which is impacted. And you can see that this tooth, the patient had come with a complaint of pain, the pain which could not be localized. And we could see from this panoramic radiograph section that there is a distal caries process that is happening on the molar, first molar. And you can see that there is a radiolucency in the interradicular area as well. So this is the information that you get from this 2-dimensional image. So when you get an additional or a luxury, I would not say it is a luxury, but the necessity of a 3rd dimension, like an axial section. This is the axial section of this image. And here you can see the coronal dimensions can be visualized. That is, the coronal dimension of the impacted supplemental tooth can be noted down. You can also see that it is palatally or lingually placed when compared to the tooth or the arch. So it is lingually placed and is in very close proximity to the mesial root of the first molar. Again, this is the axial section. Now, when you come to the coronal section, here the idea completely changes. You can see that it is not only is it proximally placed very close to the first molar. What happens is that the supplemental tooth is actually causing resorption of the lingual aspect of the first molar mesial root. So in the panoramic 2D image, you can see the whole root, and the mesial root outline can be seen, but it is confusing because in the the coronal portion, you can see that it is actually causing resorption. Supplemental tooth is actually causing resorption of the tooth, the first molar mesial root. And again, you can get all your dimensions in the coronal section as well. And in the sagittal section, we can see that even though there is a caries process that is happening on the distal aspect of the molar, the interradicular radiolucency is because of the presence of the supplemental tooth, which is causing the lingual resorption of the mesial root. So the treatment plan would completely change from either going for an endo treatment to maybe sometimes you might have to go sacrifice the tooth itself. So again, the 3-dimension adds to the 2-dimension. So when we talk about CT, CBCT, basically what we tell to the patients is that CBCT is nothing but the CT of the head and neck. So we should know what CT is and how it is different slightly or majorly different from CBCT. So in CT, what happens is that the patient is lying supine. He is lying down or she is lying down, and the gantry on which the patient is lying down is moving forward, and the X-ray source and the detectors move in such a way that you get certain cuts. And just imagine the skull of the patient to be like an apple. So the cuts that you get from a CT would be something like this. You will get horizontal cuts. These cuts, as we told or spoke earlier, would be the axial cuts. So the axial cuts are the primary cuts that you get from a CT image. Then all other cuts are basically reconstructed using computer and software, and they are secondarily reconstructed. So when you get an apple or a skull of the patient, you get axial cuts, and from those axial cuts, you can secondarily regenerate axial as well as coronal and sagittal images. But with CBCT, what happens is that older CBCTs, the patient used to be again supine, but in newer CBCTs and better CBCTs or individual CBCT machines like the one that we have in our center, here the patient is able to sit on a chair, and then the X-ray source and the detectors would rotate around the patient in a 360-degree rotation. In a single rotation, you can get the whole skull. And the cuts, if you imagine the skull of the patient to be that of an apple, it would be similar to that you get a full apple. So from that full apple, with the help of computers and softwares, you can either go in for orthogonal cuts like the axial, coronal, and sagittal. And the additional possibility or opportunity from such a image that you get is that you can cut in any way that you want. not just your orthogonal, axial, coronal, sagittal cuts, but you can also go for other cuts like your multiplanar imaging and your oblique cuts. It's a plethora of opportunities that you get from such a scan. Now, this is the machine that we have. This is the CBCT iCat machine that we have in our center. So here the patient is asked to sit, and the X-ray and the detector's source would move around the patient's head in a 360-degree rotation. And then, as I said earlier, you'll get different types of cuts here. When you imagine it with skull, you can see that from there you can either go for an axial, coronal, sagittal cuts, or you can get bone view, you can get dental view, you can get TMJ views, you can get multiplanar views, you can get a plethora of opportunities is available. Now, the other thing that is helpful with CBCT is that you can actually, collimate and reduce the exposure to the patient, and you can just get the region of interest that you are interested in. You don't have to go for the complete full FOV scan for every time. If it is, for example, if it's an implant on the third quadrant, then you can just get the third quadrant scan, whereas if you have to go for a mandible scan, you can get a full mandibular field of view. And if it's a maxillomandibular view, so you can basically adjust the field of view as per your convenience, thus reducing the exposure to the patient. And, at the same time, you can get so many dimensions within your radiograph. Now, whenever we talk about CBCT and radiographs, we have to think about certain guidelines that should be in our heads, it should be used in our practice. So the first thing and the foremost thing would be that you should go in for a proper clinical exam, proper clinical history of the patient, and only after you correlate clinically, if you once you correlate the history and the clinical examination, then you go in for your radiographs. First, you go in for your lower dose traditional 2-dimensional radiographs, and only if you need to go in for a 3-dimension, then go for CBCT. And whenever you go for CBCT, the basic knowledge of CBCT is essential, as the cuts that we might provide you or that we have to see, we need to understand basically what is happening with the CBCT, and then we will be able to better appreciate and better get to a proper diagnosis. Now, I'll move on quickly to some of the indications of CBCT in general. Now, when we talk about indications of CBCT, if you talk about endodontic applications of CBCT, or if you talk about oral surgical applications of CBCT, all these topics are a session in itself. So you have to, it is very difficult to, just combine it all together into a session. But I'll just brush through all those things, and I'll let you know how CBCT will help you add on to your 2-dimensional radiography. So I'll start off with when CBCT is required. I'll start off with, as you can all see from the image here, I'll start off with implants, implant dentistry. It is interesting to note that very recently, or 2014, a study was done on us, that is dentists in Kerala, and they were asked certain questions. And one of the first questions that were asked was that when you go for an implant site assessment, which is the most important imaging modality that you would use? Was it either IOPAR or OPG or CT or a combination of the above? And not surprisingly, most of us choose OPG. And they were asked again a second question as to why this modality was considered to be most important. And they said the third option, that is, the third option was the answer. And the third option, they say that this is because panoramic radiographs would give us a broad coverage of facial bones and teeth. Now, there is nothing against panoramic radiograph, but there are certain advantages of panoramic radiograph, like you can go for easy identification of the opposing landmarks. It is a very good screening radiograph. It's a very good screening radiograph. Initial assessment of vertical height of the bone. The initial assessment can be done. It is the keyword here is initial. Then again, the convenience of getting the radiograph, it is available everywhere. The patient does not have to wait long for your panoramic radiograph. So that again is very convenient. And also the gross anatomy of the jaws and the surrounding structures can be seen with panoramic radiograph. It is a very good screening radiograph, no doubt about it. But there are certain inherent disadvantages, like there are vertical and horizontal magnification errors that are inherent, because basically this panoramic radiograph happens with a slight tilt, negative angulation, and so there is a vertical magnification of around 10% that is inherent. Even if you get a very good panoramic radiograph, there will be some vertical magnification, and a horizontal magnification would also be there of about 20%. So this could lead to overestimation or underestimation of vertical and horizontal bone height and width, and it does not give you much input about bone quality, the mineralization of the bone. And you can see the anatomic landmarks and the various structures that are surrounding the implant site, whichever you are planning, but it is difficult to get an idea about the distance or the spatial relationship between this anatomical structure and the implant site. So that is why Pano is slowly now phasing out, and we all know that implant dentistry is mostly related to CBCT now. Now, when I was talking about the magnification, the width or the horizontal magnification is least. This is not hearsay. This is based on studies. The least width or horizontal magnification is in the maxillary molar region, whereas the most or the dangerously changed magnification would be in the mandibular anterior region. And in respect to the length, that is, the vertical magnification is least to be on the mandibular molars, whereas it is mostly seen on the maxillary premolar region. So there is an inherent defect with panoramic radiograph, that is, there is magnification errors are common. So then why go for CBCT with implant imaging? I mean, I have put it into points. One point would be that underlying disease. If at all there is any disease that could be seen very well in the CBCT, that could also be seen in OPG or panoramic radiograph, but still it could be seen properly in an CBCT. Then again, position and size of the relevant normal anatomic landmarks, as I was telling earlier about inferior alveolar canals, your mental foramina, you can when you're going for a virtual implant planning and you draw your, or you map your inferior alveolar canal, and if you we can see, if you go in for more depth, you can see that there will be a warning sign that will be seen on our software like in vivo software. So basically you can identify, and the spatial relationship between these important structures and your implant placement can be very well identified. Then again, your antra, nasal septum, your maxillary sinus, all these important structures will not be harmed in implant planning and implant placement with the help of CBCT. Then these are the two cardinal points that we always say in support of CBCT with pre-implant planning. That would be quantity of bone and quality of bone. Quantity of bone just means the height of the bone, the width of the bone, the shape of the architecture of the bone, and the quality of the bone. The thickness of the cortical plate that is present, the cancellous bone amount that is present, the trabecular space, and the thickness of the trabecular space that is present. All this can be identified with the help of a CBCT. So quality and quantity, these are the two most important points that we stress on for implant planning, pre-implant planning with CBCT. Now, when you get a CBCT scan or report, you will see that we can give you the distance that we have planned for the virtual implant from your adjacent teeth. Not only that, you can get the mesiodistal width between the teeth for a single tooth implants as such, and you can get a 2 millimeter width, every 2 millimeter width, and the proper bone height. So all this is information that you can use to properly guide your implants into position. Now, we always ask our implantologists to, if it is a multi-implant placement or completely edentulous arch, we always ask them to give us certain radiographic markers which can be put on your base plate or your existing dentures of the patient, and these radiographic markers can help us with identifying the areas that the implantologist requires to put the implant. This will guide not only us, but it also will guide you to a proper implant planning. So here you can see that those thick radio-opaque markers are nothing but gutta-percha, which has been drilled into a base plate, shellac base plate, which was given as a cast. And you could see in three-dimensional radiography also those bullets, and With the help of those radiographic markers, we could easily identify the place wherein you need your implants to be planned. So these are things give and take that will be required with the radiologist and the implantologist to go for a proper planning. Now, surgical guides are something wherein we can plan the implant for you. We can we can prepare a surgical guide wherein we can put in the angulation of the implant. We can put in these vertical stops and the angulation such that you don't even have to raise the flap. You can just drill it and just forget it. So that is how the surgical guides can be used. Right now, we don't use that in our center. We take the scans with the help of a third party who plan these surgical guides and implants, and then they give you the surgical steps. So with the help of a third party software and third party, we can always go in collaboration with them and prepare such surgical guides which will help you in very easy implant placements. So now this is about implant dentistry. I'll just give you the characteristics of the ideal imaging technique that is required for placing pre-implant planning. That is, you need to visualize the implant site mesodistally, faciolingally, superior, inferiorly. All this can be done with CBCT. You need to have a proper axial orientation of implants that can be properly identified with the help of CBCT. You need to have reliable and accurate measurements, and this also can be identified, given by CBCT. And trabecular, as I was telling about quantity and quality of the bone, the trabecular bone density and the cortical thickness can also be seen. You can correlate your site with the clinical site because you can get life-size images and you can measure and do on the patient on chair side. And obviously the access and cost to the patient and minimal radiation risk are other points that we need to understand. So whenever we are talking about implant dentistry and CBCT, it is very good that we go for a CBCT technique before implant planning or before we place the implant. Intraoperative or post-operatively, we would suggest that the best radiographic method to observe or assess the implant that has been placed would be the IOPR, intraoral periapical radiograph, because of certain inherent defects in the CBCT machine. We will talk about the limitations of CBCT later. Now, when we talk about implant dentistry, then comes endodontics. This is just shoving it all in together to just give you a brief idea about how CBCT can, help you with your daily practice. Now, in endodontics, from this article, I got these as the most important indications for CBCT. CBCT. Evaluation of root canal anatomy and complex morphology, detection of periapical pathology. I'll not read. We'll talk about all these things with the help of certain cases. So the first case is of a certain 16-year-old female patient. She had a complaint of pain in her right upper anterior teeth, and on clinical examination, as you can see from these images, that nothing can be quite visualized except that there is a lingual groove on the lateral incisor. And when an intraoral periapical radiograph of the same patient was taken, I hope that all can see a radiolucency on the distal apical third, middle third and apical third of the lateral incisor. Is there anything else that is visible in the intraoral periapical radiograph? The lingual groove can be again seen. But now, when we take a three-dimensional radiograph like a CBCT, the third dimension will help you see that in the axial sections, the D, the images marked D, you can see in the axial sections that there is a radiolucency, which is the pulp chamber, and then there is a radio opacity surrounding a radiolucency just palatal to it. So if there is an invagination of enamel into the dentine in the radicular portion, then we call it as the dens indentae, or tooth within a tooth, right? So this is a case of dens indentae of the lateral incisor, and that is what is causing this lesion, periapical lesion on the tooth. And with the help of this information, the endodontist could well go ahead with the root canal. And this is the immediate pre-operative, post-operative radiograph. And here you can see that they have only taken a CBCT for a pre-operative scan, whereas all peri-operative as well as post-operative. So this image that has come now to the screen is a 1-year follow-up radiograph. Here you can see that the periapical lesion is completely healed. So CBCT is required only before planning. For observation and for assessment, it is better that you go in for your traditional 2-dimensional radiographs. If that does not give you a proper image, then maybe you can go in for CBCT for evaluation and assessment. Now, another case that we will discuss about here is that this again is a sectional panoramic radiograph, and you can see we are talking mostly about the second molar here. You can see that it is carious, but can you see something else in this 2-dimensional radiograph? When we go in for its axial section, you can see that there is an additional canal and an additional root that is present on this tooth, and this could be identified with the help of a 3-dimensional radiograph like a CBCT. Now, in this particular case, you can see that the central incisor, the radiolucency suggesting the pulp chamber is, it is only till the middle third of the root, and from there you can't see any radiolucency. So the pulp chamber is calcified. But with the cross-sectional images, you can see there is a small thin layer of pulp chamber still viable, and you can go ahead and very well go on with your endodontic treatment with the help of this CBCT. So calcified canals, missed canals, or extra canals, I'm sorry, calcified canals, extra canals, and even, certain morphologically different root systems can all be assessed with CBCT. Now, consider if it is not in the roots, it could be in the periapical region. Just imagine here, this is another case where in a 40-year-old female patient, you can see that the clinical radiograph show there is a discoloration of the canine, which is, it looks like it is non-vital. The intraoral periapical radiograph clearly shows that it is calcified. There's a thin pulp chamber that you can see, but nothing else is visible or appreciated. When you go in for a CBCT of this case, you can see that the axial sections show that it is calcified, but after middle third of the roots, there is a small pulp chamber that is visible till the apical third. And cross-sectional images would show something that you couldn't see in the intraoral periapical radiograph. You could see that there is a small periapical pathology. So such periapical pathologies can be visualized. And with the help of this, the doctor, the endodontist, could start off with the endodontic treatment. But here you can see that the red arrows show the scouting of the canals, wherein the endodontist could not reach the pulpal canal properly. So they went in for an peri-operative or intra-operative CBCT scan. And that's what I'm saying, that CBCT scan always pre-operative, if needed intra-operative. See, they went for an intraoperative CBCT scan, second CBCT scan, wherein they could see that they were going in a wrong direction. And with the help of CBCT, they could then adjust their path and they could get to the pulp chamber and do a proper endodontic treatment. Now, you have done with your root canal treatment. So to assess your endodontic failures or to learn from them, you can use CBCT as well. Here in this particular case, you can see that RCT root canal treatment has been done, and there is a prosthetic crown as well. But you can very well see that it is under-obturated. But is that all? When you take an axial section, you can see that in this particular case, the endodontist or the doctor missed a canal completely. So that can, to assess the effect of, or the outcome of the root canal treatment, you can use this. And whenever needed, you can go in for pre-endodontic surgical planning as well. Here, in this particular case, the patient went in for 2 root canals of the central incisors, but you can see that there is a periapical lesion, a large periapical lesion in the intraoral periapical radiograph. And with the help of CBCT, you could properly gauge the dimensions of the axial, that is the mesiodistal dimension could be understood, the buccopalatal dimension could be understood, the superior inferior dimension could be understood. So with the help of the CBCT and the third dimension, you could easily open up the flap and do a proper apicectomy procedure. And the H image would show you the immediate post-operative radiograph, and it was sutured, and the 1-year post-operative radiograph shows complete healing. So CBCT can be helpful here as well. So now to talk about assessment of root fracture, resorption, perforation, again, I will use another case. Here it is iatrogenic resorption. Perforation. You can see that in this particular case, the patient came with complaint of pain. You could see that it was completely under-obturated, but with the help of a third dimension with the CBCT, you could see that they had not only under-obturated, basically they had gone somewhere else into the buccal cortical plate, and with the help of the CBCT and 3D imaging, we could remove the gutta percha, the endodontist could then correct it, and with the help of a flap, do a resin-based filling over the root. Thankfully, it was in the cervical third, and then you could see a post-operative follow-up radiograph wherein it has healed completely. So there's again another example of a case wherein assessment of resorption, perforation, root fracture can all be done with CBCT. Now, when I was talking about root fracture and crown fracture, you can see in the intraoral periapical radiograph, the fracture is not quite visible, although clinically it might have been visible. But here you can see in the cross-sectional images that the fracture is actually going off in an angle and involving the cervical third of the root as well. So these are examples and cases wherein endodontic CBCT can be applied for endodontics. Now, we need to again go in for oral and maxillofacial surgical applications of CBCT. I'll just rush off briefly through it. Now, these are the basic indications that we might need CBCT for. As I have bundled so many things into oral surgery, general dentist can also be anyways going to, they might also do these things. Now, when we talk about impacted teeth, that's the first indication that we are going to talk about. Here you can see there's a mesioangular impaction of the third molar, and when you take a cross section of the tooth, you can see that the impacted tooth is seen. The mandibular canal can be very well visualized. The opposing tooth can be visualized if it is taken in that field of view. The tooth position, the thickness of the buccal and cortical plates can be visualized. The nerve location and how it is distant to the tooth can be localized. In this particular case, you can see that the superficial or the superior border of the nerve is thinned out. That is, there is a very close proximity with the tooth. So for evaluation of impacted tooth, here again there is another case. In this particular case, the impacted tooth is the first molar, most probably a first molar or second molar. Here you can see, because there is communication with the external area, there is a decay process that is happening in the enamel and dentin, but it is difficult with this two-dimensional image to say whether it is buccally placed to the inferior alveolar canal or lingually placed. Now, with the help of 3D, we can see that the caries process is happening in the lingual process and lingual aspect, and the canal itself is placed lingual to the tooth, and the mesial root is actually curving around the canal. So this will help you in guiding or how to gain surgical access for this particular case. Again, another radiograph and another panoramic radiograph wherein you can see two central incises. Mandibular central incises are actually impacted. But if you look carefully, there is a small radio opacity which is surrounded by a thin rim of radiolucency, and pericoronally that radio opacity would be, mixed radio opacity would be that of a odontome, right? So you can visualize the odontome here. See, the odontome is visualized here properly. You can see the odontome can be seen properly. So such images, that is three-dimensional videos, can also be given, which will again guide the dentist and the clinician about how to go about with your practice. Now, another kind of impaction would be that would be seen mostly by the orthodontists. Here, canines are being impacted, and there's a bilateral canine impaction, horizontal impaction, but you can't say whether it is palatally placed or lingually, buccally placed, whether it is causing resorption of the central lateral incisors. So when we get a three-dimensional image wherein you get the proper image of how the tooth is placed, how it is buccally placed compared to the arch, how it is laterally and placed in the left side as well as the right side, all this can be obtained. There is, you get all the two-dimensional images as well as something more when you use a three-dimensional image. You get the whole, how it is closer to the nasopalatine canal, how it is away from the tooth of the, root of the tooth. All this can be obtained. The relationship with the adjacent structures, all this can be obtained with the help of CBCT. Now, when we talk about oral surgery, another thing that would be effective with help of CBCT would be orthognathic surgery. Here, in this particular case, who had come to our photonics imaging solutions with a case of skeletal class 3, and you could see we could generate a soft tissue window. We can generate a true panoramic window. We can generate an AP bone window, AP dental, lateral dental and bone windows. So there are so many types of radiographs that you can take from one exposure. Not only that, if we take the impression of the cast of this particular patient, the CBCT of the patient cast can also be taken, and then with the help of a third party, right now we are sending it to CTAS in Chennai, where Dr. Nason would be helping us out. Here, he can actually, with the help of the CBCT scan that we have actually sent to him, plan out the proper surgery even before touching the patient on the operating table. Here, he can go in for a leaf out cut, and he can actually virtually move the cast in such a way. He can do the BSSO cuts, and he can move the mandible also to the required position. He can prepare a splint, surgical splint, with all these images that are obtained, and he can even say after surgery which teeth will have some occlusal interference. So even without seeing the patient, this doctor is in Chennai, he has not seen the patient, he has only seen the scan. Without even seeing the patient, he can do a proper orthognathic virtual surgery on the patient and get you the casts, and you have to then again go into the operating table and do it as per the surgical splint given. So this is a very novel and wonderful application of CBCT again. I was always telling you that CBCT is usually done pre-surgery or pre-procedure for planning. But in certain cases, like in this orthognathic surgery case, we can always go in for a pre-surgery. You can go in for post-surgery evaluation also. So CBCT can also be used as an evaluation tool in certain areas. Now I'll just give you image or a video wherein, as Dr. Vinisa was saying, it is really fun, but it can also be, you can see that once you can, if the patient's photograph is with you, you can easily warp the photograph onto the soft tissue contours that you go through the scan, and you can, verify the views, you can verify the results, you can show it to the patient, you can use it as a patient education tool. So the opportunities that you have with CBCT, mainly with respect to surgical planning, are too good. So I'll just skip this video now. Now again, I was talking about oral surgery. We were talking about impactions. We were talking about orthosurgery, planning and evaluation. Now about pathologies. These are some of the cases that might come to your clinical practice day in and day out. Here, for a single pathology that is on the maxilla, periapical lesion on the maxilla, which is a very large periapical lesion, the doctor had to go in for 5 radiographs to actually get the boundaries. Even then, they couldn't get the superior boundaries. So, panoramic radiograph will help you with it, but again, the anteroposterior or the how palatally it is extended can't be visualized with the help of a panoramic radiograph. And with the help of CBCT, what you get is the axial sections on the top, wherein you can see the palatal extension, how it is involved in the palatal cortex and the buccal cortex and the anterior nasal spine and all that. You can also get cross sections of the image, and you can see how it is affecting the nasopalatine canals and how it is affecting the buccal and lingual cortices, how it is affecting the nasal flow and the sinus. All this can be visualized with a single radiograph. So that is the help that you can get from pathologies in CBCT. Now, as I've written at the bottom of the slide, dental maxillofacial trauma and its assessment. Here, I have given you a radiograph here, a panoramic radiograph, but can you see any the patient gives a history of trauma, alleged history of RTA, and is there any signs of fracture that you can see? All that I can see is a increased joint space in the right condyle region. But that's all that is basically visualized in this OPG. But when you take a 3-dimensional radiograph and use the bone window, here you can see that not only has the condylar neck fractured, it has displaced laterally, and it has displaced inferior, anteriorly. And that is why, because it was overlapping in the particular panoramic radiograph, you couldn't see the proper boundary that was disrupted. only the joint space was appreciable there. But in here, you can see the lateral displacement as well as the inferior displacement. Again, another case of trauma, wherein the obvious thing is that patient has hit the symphysis region, the parasymphysis has got fractured. And do you see anything else? The clinician also couldn't see much, but he was, knowledgeable enough to go in for a CBCT, and with the help of CBCT and 3D, evaluation, you could see that not only was there a bilateral parasymphysis fracture, but the lingual aspect, lingual cortical plate had completely comminuted and completely gone off the arch, and it was embedded within the soft tissue, and it was not even visible clinically. So this is how if you have to go for a 3D reconstruction in CT, that will again cost the patient too much. But here, these things can be easily identified and sent over social media apps like WhatsApp. So such things can be easily communicated to the clinician with the help of CBCT and the various softwares that come along with it. Now, when we talk about panoramic radiograph, as oral medicine radiologists, we take so many X-rays for TMJ. That is, we take transpharyngeal arch, transcranial root mode. You can go for a transpharyngeal mode, then you go for your transorbital mode, all for this visualizing the TMJ, and it is not again visualized properly. But what we need is a single modality and a single exposure for diagnosis of TMJ. Here I have brought you another case wherein you can see that the patient is partially edentulous. There is obvious deep bite that is happening, but can you see something in the condyles? On the left condyle, you can see that it is slightly tilted. What is happening here is that the left condyle, there is a vertical fracture or vertical cut that has happened, and this vertical fracture may be pathological fracture, and that might be the reason for the patient's complaint of difficulty in opening. We can see the TMJ in all its entirety from all the angles. Not only do you get the three-dimensional bone window, you get sectional windows wherein you can see any subcortical cysts, any cortical erosions, joint space measurements, the difficulty in movement, all this can be seen. All the bony pathologies can be visualized with the help of CBCT. But mind you, if it is a disc, articular disc related soft tissue pathology, then it would be helpful to go for an MRI rather than go for a CBCT. Now, to the last of the topics, orthodontics, again, we go for many radiographs like OPGs, lateral cepts, your APs, PAs, and all that. All this can be obtained with a single scan, single CBCT exposure. You can get your true panoramic radiograph. You can get your true cephalograms in various colors and shapes with the help of the CBCT with a single exposure. The panoramic radiograph and CBCT, lateral cept with a single exposure. You can, if you are academically oriented, going for a certain analysis, and 3D cephalometry can help you with this. We need to just mark out certain landmarks in the patient scan, and the software will do the analysis on its own and give you the measurements and the parameters. Now, when we talk about orthodontic applications, again, dental structural anomalies like multiple impactions can be very well visualized. The images here shown in this particular picture is not that great, but again, multiple impactions can be properly identified. If there is a dental position anomaly, that is, I was talking about impactions in canine impactions. You can see this particular canine has grown completely. The root formation is complete, but still it is not out. It is because of the presence of a supernumerary tooth, which is blocking the cingulum of this tooth. So, anomalies in teeth position, then dento-alveolar morphology defects like cleft palate and its analysis. So there's a basic complete session that we can go on for cleft palate analysis and morphology analysis of using CBCT. Again, airway and other maxillofacial pathologies. Now, for orthodontic purposes, right now we provide the orthodontists with so many analyses. Just a few of them I am showcasing here. You can go in for mid-palatine suture maturation analysis. This is helpful in rapid maxillary expansion for adolescents. And then you can go in for a very detailed airway analysis. This can be used for your rapid maxillary expansion before and after your orthognathic surgery. If your airway is compromised after your BSSO, where your mandible is pushed back, you get so many parameters through which you can, analyze your treatment. Then again, for MARPE, that is mini screw assisted rapid palatal expansion, you can get parasitical measurements at the premolar, first premolar, second premolar, the molar levels. So you don't have to go blindly with your mini implants. You can properly have a guided, implant placement, even for orthodontists. So now I have rushed through CBCT applications, more or less the main applications. I will like to touch upon certain strengths of CBCT for potential buyers of CBCT. It is 1/4 to 1/5 the cost of a conventional CT when compared to a CT, and because the patient is sitting upright or standing upright, the physical footprint itself is reduced. Then the acquisition time is fast. That is, there is a rapid scan time comparable to OPG. The OPG that we take nowadays, the scan time would be around 20 seconds. In our photonic imaging solutions here, the longest scan time for a CBCT is 26 seconds. So it is very much comparable to an OPG scan in terms of the time for the scan required. And the resolution that we can boast of is about 0.125 millimeter. That's the smallest resolution. That is, you can identify 2 points closely set together, 0.125 millimeter apart. So that much of visual effect can be obtained with the help of CBCT. Again, patient dose is comparatively less. That is 98% reduction when compared to a conventional CT. And it is comparable to a full mouth series of intraoral periapical radiographs, or if it is a small FOV CBCT scan, it is comparable to a single or up to 3 panoramic radiographs. So the amount of radiation that is going to the patient, as can be also seen from the figures, is very less. Now, another thing that I have told you, before as well, that is the field of view can be reduced with the help of collimation, and that also will help or aid in patient exposure reduction. As I was telling earlier, fast scan times. Now, again, when you talk about strength, you need to know about limitations as well. We always tell our endodontists and our general dentists and our clinicians to always, if possible, remove metallic objects like crowns or gutta-percha from the canals and area of interest, so that you don't have something like a beam hardening artifact. Here in this particular cadaveric cadaveric sample, you can see there are 2 gold restorations, and the same section has been scanned, and you can see that because of the gold restoration, there are multiple streaks and bands, radiolucent and radiopaque streaks and bands, which is hindering the ability to diagnose a certain condition in that section. So it's always better to remove the metallic objects or GB points and cones if you're going for a re-evaluation with your CBCT. Then again, if patient is moving too much, patient-related movement artifacts obviously are there. Then again, scanner-related artifacts. We always do in our center. We always calibrate our machine every week. So that is how you need to control the scanner-related artifacts. So there are, again, that is again session limitations of CBCT. Poor soft tissue contrast. So if we need to go in for soft tissue scanning, and if you need to go in for articular disc pathology, as in case of TMJ, it's always better to go for an MRI and not to go for CT or CBCT. I stop with this. This is not an absurd image. This is Prince William. Yeah. From this angle, it seems very weird. But basically, he was being very happy. He was just showing, he was out of the hospital. His wife had delivered their 3rd child, and he was just showing off that it is number 3. But from this angle, it looks very weird. So you always need to have another dimension, even in life, even in radiography, even in your dental imaging modalities, so that you get a better treatment plan and diagnosis going. So the take-home message from all this ranting and rambling would be that you need to use your CBCT judiciously. You might not get the whole story from 2 dimensions always. And always correlate your clinical history and 2-dimensional radiographs first, and use CBCT ethically. That is obvious. And then you need to know your axial, coronal, sagittal sections. What are those? When we talk about CBCT and the sections, you should know all these terminologies basically. And learning never stops. We are still learning. So you can always contact us at PHOTONIX at this number. You can email us, and this is basically it never stops. Learning never stops. So that is it. Thank you for giving me this opportunity, IDM Malabar, and thank you for a well-conducted, seminar. Yeah, thank you so much. I mean, I'd like to point out, because I had shown that the slide is basically not very clear, but by this end of our session, I hope the understanding of the CBCT, a brief exposure, is a bit more clarified, and the picture itself is a bit more clear. Yeah, I mean, that is all that I have to say. Thank you. I mean, your audio is muted, Dr. Oni. I mean, I can't hear.
Thank you.
Right.
Thank you, Vivek. I hope this has been a brief insight into CBCT. Very good, very well conducted. Gatapacha for edentulous patient was a very new information for me. I regularly use Gatapacha. Gatapacha is always inside the tooth.
Gatapacha has other uses as well.
Right. Any doubts? Anyone wants to ask any doubts? You can put into the chat session, or you can unmute yourself and ask. We'll be taking.
Shall I stop sharing the screen now?
Yeah, you can stop. You can stop. Yes. A lot of compliments on the presentation.
Yeah.
It's coming up. You can see the chat box.
Yeah, I see.
And that Chennai reference was also very good. You don't have to see the patient. You can form splints and everything. That's very advanced technology.
It is right at our doorstep.
Yeah. We had over 45 participants.
Nice.
It was also live streamed, and it will be available in our IDM Malabar live channel, also YouTube live channel.
Okay.
If anyone wants to go and look back into session, have a second look, it's also possible.
Always contact. I mean.
Yeah, if we have any doubts, you can contact that number. You can contact Dr. Vivek directly. He's there. Can you enlighten on the image magnification? Is it same as that of the clinical size?
Thank you, Asaf, for the question. Basically, in CBCT, you can always get image magnification in 1:1 ratio. That, I mean, images in 1:1 ratio. That is life-size images, and even life-size image printouts are available with CBCT. And those images can then be taken out, and on the chair side itself, the clinician can very well measure using your normal meter scale and assess the height and width of the bone. I'm talking about implant planning here.
Okay.
So, I mean, 1:1 ratio, I mean, with CBCT, more or less, it is 1:1 ratio. There might be certain distortions happening when there is a term called stitching of volumes. This happens with our smaller grade CBCT machines, wherein it is a combination of OPG with 3D imaging and lateral ceph. The patient will have to stand and take the radiographs. And in such cases, sometimes when you go for large FOV scans, you might have to stitch two scans together, and that might lead to a certain amount of distortion. But when you go for a standalone CBCT machine, then you don't have such an issue as such.
All right.
I hope I was, audible, and I was not fast. I'm done.
Any more questions? Please feel free to ask. I had done a case in my PG for that Densin dente. That was also very. I had done 2 Densin dentes, and that was CBCT was very helpful.
Yes.
And then you get to even get the measurement, working length, working width, everything.
Yes.
That is good.
I mean, with endo applications, I mean, as I was saying, every application you'd have to go for separate sessions to, speak in, detail about all these things.
Definitely, maybe next time, sir, when we have a bigger time schedule.
Yes, definitely.
You were right on time also, correct 8 o'clock.
Yeah.
1 hour.
Personal,
yeah.
So I had to go a bit fast. I hope I was clear enough, even though I was a bit fast.
How can you compare CT and CBCT in accessing facial fractures? Okay, usually we advise CT for assessing facial bone fractures. Now, how do you compare CT and CBCT for assessing facial fractures?
One of the things is that with CT, CT is the imaging modality that's usually present in all the hospitals, and it is when there are facial fractures happening, most probably the patient might be ambulatory, might not be ambulatory, and the patient might have other major issues to be taken care of, and going to a center, CBCT center, would be difficult. So that is the practical difficulty attached to it. But with technical thing is that with CBCT, you can get a better, you can get a better scan of the facial bones as such, and the contrast resolution and the spatial resolution would be better than CT. And because maxillofacial radiologists would be the ones who would be, assessing the scans as well, they will be better off talking about such things. Radiologists might miss out. Maybe they might not feel that. Our dental radiologists might miss out on certain things. And as I was showing that particular case, which came to a hospital, and he was referred to a CBCT after there are parasymphyseal fractures were happening, but the thing is, the lingual part had communicated, and there was a communicated fracture on the lingual part, and that part had actually embedded into the soft tissue, and it was not even visualized clinically. So, and to put another point is that 3D reconstructions with CT would be again another cost factor for the patient, and it is not usually given out with every CT. We have to put in a particular request for a 3D reconstruction scan along with our CT facial bones. But with CBCT, as I said, because you get the whole apple, then you can, with the help of software, get the 3D reconstructions readily available to us, and this can be easily communicated to the doctor using social media apps and all that. So 3D reconstruction is again another point where CBCT can score.
Right. The question was from an oral surgeon, so yeah, I guess she might be.
They might know better.
We don't know better. So they might be having CTs more. They might be seeing CTs more. If the patient is ambulatory, if he is able to go for a CBCT, CBCT is always better.
Obviously, I'll say that CBCT is always better. CBCT can be better, yes.
What is this micro CT, doctor? Micro it's entirely different, I guess.
Micro CT, CT can be classified into many things. That is multi-detector CT, your conventional CT, then there are multi-detector CTs. And with that, in that comes micro CT, wherein resolutions can be as low as 40 micrometer or something. And that is usually done, helpful in studies and other, academic purposes. I think I'll have to go through micro CT some more before I can answer that question. Whoever has asked the question, I'll get back to them. I think that would be better.
It's okay. That's basically when you get in vitro studies and all regarding
basically
this.
Academically oriented things you can, blood vessels and all that, I think.
Okay, how recommendable is CBCT for soft tissue imaging, like hemangioma?
If hemangioma is a great mimicker, it can mimic everything. If it is intraosseous, obviously CBCT can be helpful. But if it is soft tissue hemangioma, then it would always be better to go for soft tissue. For contrast CT and contrast enhanced CT or your MRI or your USG for your initial screening purposes. If it is intraosseous, obviously, if it is bony related, then you can go in for hemangioma. I mean, you're going for CBCT with him.
Yeah.
Hello, Dr. Vivek.
Hi, Ravish.
So I just wanted to ask you regarding the trauma. If you are taking the orbital views and all, will it be able to identify the entrapment of muscles and all?
Because we don't use usually we don't use contrast enhanced systems. But with I think with CT also for facial bones they don't usually use contrast, and it is whatever can be visualized in CT can be very well visualized in CBCT. For even for ENT applications, I mean, I'm just deviating from the topic, your question. Even for ENT applications like the ossicles, everything that you need to see in your ENT area, that ear area, that itself can be visualized. Those minute bones can be visualized in CBCT. And so, I mean, muscle entrapment can very well be visualized. It is just about us understanding more about the anatomy of that region.
I mean, my question is, if I get a patient, I can very well send it to you as well. I mean, for the CBCT,
definitely.
Rather than sending it for the normal CT, because that's what we look for in the orbital floor fracture and all.
Yeah.
And
it is very much possible. We can.
Okay, and this thing obviously brain and all won't be seen. This is just a doubt for me.
Yeah, I mean, we will have to brush up as maxillofacial radiologists, as we are maxillofacial radiologists.
No, I'm just asking whether it will be seen or not. I'm not asking about the details, whether it will be seen or not, or can you use it as a alternative for regular CT? Is it possible?
I wouldn't suggest because CT is never. I mean, CBCT is never substitute for CT. CBCT is never a substitute for CT, but certain things can be visualized. But soft tissue like brain and all that, maybe because we haven't seen a case ourselves. I'll have to get back to you on that after going through literature, because in our center
I just asked. Definitely CBCT has been helping us a lot with even the regular impaction, implant planning. And it is like implant is almost like without CBCT, we don't want to plan anymore. So it is that old of opening up a flap, seeing there is no bone, putting in graft has changed. You can plan, you can tell the patient you have to go for graft, you have to go for this size. Anyway, this was a very good, very good presentation.
That's a window, opening of window.
The splint part, I was not aware of it. I'll get back to you regarding that.
We will talk about what you're asking. We'll definitely see.
Okay. Thank you, Vivek G. Very good presentation.
Thank you so much. Thank you.
Bye.
Right, Vivek. It was a very good presentation. If there are no more doubts, shall we wind up?
Okay, from my side.
Okay. To all the members who have participated, to everyone who have been present here, thanks a lot for spending your 1 hour after clinics. I know it's a hectic schedule. We'll wind off. Thank you so much. Thank you, Vivek, for spending your time. Thanks a lot.
We'll be in contact.
Yeah. Bye-bye. Thank you.
Right. Good night.